Thank you to everyone for joining us for today's webinar. I'd like to thank the funders of Cochrane Canada, without whom these webinars, our training, systematic reviews, and capacity building could not happen. Thank you to CIHR for their support. I'd also like to thank PAHO for kindly providing the software for our webinars. And a special thank you to Louis Gabriel Cuervo, who produces videos of our webinars. Without further ado, I'd like to introduce today's webinar on an introduction to rapid reviews. We'll be hearing from David Moher, Adrienne Stevens, and Chantal Garrity. David Moher is a senior scientist in the Clinical Epidemiology Program, Ottawa Hospital Research Institute, and associate professor, Department of Epidemiology and Community Medicine at the University of Ottawa. David is also a co-convener of the Cochrane Bias Methods Group. Under David's leadership, the Knowledge Synthesis Group has been involved with various rapid review initiatives that will be described today. Adrienne Stevens is a clinical research manager with the Knowledge Synthesis Group at OHRI and serves as an associate editor for the Journal of Systematic Reviews. She has been involved with systematic reviews for more than a decade, including education and training with Cochrane, and has been conducting and leading rapid reviews as part of OHRI's rapid review portfolio. Chantal Garrity is the Senior Operations Manager for the Ottawa Methods Center, based at the Ottawa Hospital Research Institute, and has over 15 years of experience managing and conducting knowledge synthesis research. Since 2011, she has been leading the Rapid Reviews portfolio at OHRI, which has included leading and conducting rapid reviews, providing training and education on rapid review methodology, and being actively involved with establishing guidance for the Cochrane Innovations Rapid Response Initiative. David and team, please go ahead.
Thank you, and I think it's probably good morning and good afternoon everywhere across Canada who's signed on. So thanks for the introduction, and the session is going to be given by the three of us. And just to give you some context about our group, we're an academic group in a clinical epidemiology program, and we've done all sorts of knowledge synthesis for quite a long time. And a brief outline of how we're going to spend probably the next 50 minutes and describe our role in rapid reviews, the approach that we've used, our involvement with the Cochrane Rapid Response Initiative, what are some of the challenges, opportunities, and lessons that we've learned, and then we will take questions after each session. I'm going to do the first section, and that's going to be followed by Adrienne and Chantal. So here is the first poll. I'm going to ask people if they could sort of answer how many have conducted a rapid review. And so this very dynamic poll is coming in, and we'll wait to see what it says. But it looks like about 2/3 of the, I'm going to say nothing until it's finished. Okay, so it looks like about 50% have not, and about 20% have. I'm not sure what I guess, does the 30% mean none? I don't know what that means, because there's only 2 questions. But it looks like most people have not done a rapid review. And so the next question is, how many have used rapid reviews in decision making? A is yes, B is no, and C, should I say, is not a decision maker. So the results are coming through quickly. Okay, so it looks like about 10% have used rapid reviews in decision making. About 17% have not, and about a third, or 36% to be more precise, are not decision makers. Okay, so thank you for taking the time to answer those two questions. And so really, what is a rapid review? And I think probably one framework to look at this issue is to compare it against a systematic review. So I think many people would agree that systematic reviews are done in a period of 6 to 24 months, whereas a rapid review is really a much more compressed time frame. I think sometimes the question of a systematic review is clinical, although that certainly could be in a rapid review, but there may also be some broader questions. The sources and searching of a systematic review might be quite comprehensive, whereas for a rapid review they might be far more targeted. I think the selection of a systematic review might well be a priori, but I think there may well be cases in systematic reviews where they're post hoc as well, and that is I think the case for rapid reviews. I think the big issue I would say here is, regardless of the approach, to the notion of being transparent and honest would be good for the reader to know about. The appraisal process, such as risk of bias, would be similar across both approaches. The synthesis, certainly for a rapid review, might vary and might differ than that of a systematic review. And I think it also, the inferences may also differ differ between a rapid review and a systematic review. So I think there are some broad differences and similarities between a standard systematic review and what we call a rapid review. So just to give you some context as to how our group got involved, we are part of the Champlain Local Health Integrated Network. So the LHINs within Ontario essentially are how I think healthcare dollars are run. They're run through the LHINs, and those LHINs then spread it out towards hospitals, community centres, etc. And we have a large concentration of knowledge synthesis and knowledge translation expertise in Ottawa, and we got involved with our local, with our LHIN in 2009, when Jeremy Grimshaw and myself had a knowledge to action grant, and we were helped enormously in this grant with Sarah Kangura, Christian Conyu, and Rob Cushman, who was at that time the head of the LHIN. And it was almost, I would think it was almost sort of a dating game with Rob, because we wrote the knowledge to action grant and we weren't quite sure what to do because the LHINs were quite new. And so we met with Rob quite a few times to sort out actually what would we do. And it came out that that the LHIN were most interested in rapid reviews, and so we were all excited about that, and UD panic-stricken because we really didn't know how to do these. So I think we did one sort of sensible thing, as any sort of systematic reviewer will tell you, is we went out and searched to see what's out there to guide us, and there wasn't a lot of stuff out there, but there were some very good gems. So one of the papers was by Amber Watt and colleagues, and if memory serves me, they're an Australian group, and they really set out to sort of look at what's out there in terms of guidance And they also wanted to ask whether the results of rapid reviews differed from the results of traditional systematic reviews. And what they did is they surveyed HTA organizations, health technology assessment organizations, and they also surveyed groups on a range of themes related to rapid reviews. And what they concluded in the report was that there was little cohesion between organizations regarding the content, methods, and definition of what constitutes a rapid review. And I think that's an important issue, because if we're going to talk about rapid reviews, we ought to actually be on the same page as to what do we mean by rapid reviews. So I think that was an important piece that they brought to the table. Now, this group also asked, which I think is a really relevant question, is whether the results of rapid reviews differ from systematic reviews. And I think they made an initial foray into that question, and what they did is they compared, retrospectively I might add, they compared rapid reviews, 7 rapid reviews on 4 particular topics. And what the key finding was that the conclusions did not differ extensively between both approaches. And I think one can read that paper and see there are some probably some methodological challenges in that work. And there's a very nice piece from the McMaster team. Rebecca Gannon has published in Implementation Science. Again, looking at rapid reviews, and they did a scoping exercise to find articles related to rapid reviews. And they found 45 methodological articles discussing rapid reviews, and examples of 25 rapid reviews, and the team concluded that rapid reviews employ a variety of labels, timelines, and methodologies. So I think that was another important contribution. And rapid reviews have also been used in a variety of other settings, such as the Harker paper, and Harker and Jaskleinen published this really quite recently, looking at issues around rapid reviews, and they provided a snapshot of the evidence from a larger pool of rapid reviews and health technology assessment, and found that the majority of rapid reviews took between 7 and 12 months, and a few rapid reviews mentioned the limitations. And so I think this is interesting. I myself wouldn't have thought a rapid review would be something that you would do in 7 to 12 months. I think you would probably want to do it much quicker. And finally, what we found is Bambra has also looked at rapid reviews in the context of policy making. And I think this is a sort of a really interesting area as well. So I think the take-home messages when we looked, there's no a universal accepted definition on indeed what a rapid review is. There's quite a limited literature, at least published literature, to guide the process. There seems to be variance on nomenclature, methods, time frames, and report formats. So I think they're cautionary tales, but also exciting opportunities to move the field forward. And I think one always needs to be mindful of the limitations and biases when we're trying to do something in a much more compressed time frame, because we do have to cut corners. For example, we may only search 1 or 2 databases as opposed to 3, and what are the consequences of that? And rapid reviews definitely do have the potential to inform policy and practice, but we need more research, and that is an exciting opportunity. I think that is all that I was going to say, and I thought we might stop here for a moment if there are any sort of questions, important questions that people wanted to ask now, or we could hold the rest of the questions until both Adrienne and Chantal have spoken. So any questions that just have to be answered now. If not, I'm going to pass it over. So it looks like everybody is comfortable. I may have put people to sleep, and that might be why there are no questions. And so I'm going to throw it over to Adrienne and Chantal.
Thank you, David. We actually do have one question, so if I can just have you come back, I'll read it out loud. It's from Mags. Mags wanted to know, are you planning on a consensus exercise to define rapid reviews more clearly?
All I can say is that I have a graduate student, Shannon Kelly, who is finishing off her master's. And one of the focal points of her master's is to actually get and answer this question, trying to get a consensus across a spectrum of stakeholders as to what that might be. And I think we have possibly an answer, but I certainly don't want to divulge the results of Shannon's thesis, otherwise she might do me harm. But the answer is yes, and it's coming.
Thank you, David. We'll just give you maybe 2 more questions quickly, and then we'll save the rest for the end. Marla would like to know, what is the difference between a rapid review and a scoping review? And then we would like to know, do journals accept rapid reviews for publication?
Okay, so I'll answer the second question first because my memory is not good. And rapid reviews are accepted for publication, and my competing interest is I'm editor-in-chief of Systematic Reviews, and we are very interested in rapid reviews. And it's quite surprising to me that more rapid reviews are not submitted for publication. And so I encourage everybody on this call who does rapid reviews or have done rapid reviews to consider submitting them. Maybe you don't like systematic reviews, and that's absolutely fine. Send them to a journal. I think it's really important to get them out there. I think there are many differences between scoping reviews and rapid reviews, and I would say the fundamental difference would be the level of how much you drill down. So in a scoping review, you typically wouldn't be doing risk of bias assessment, whereas in a rapid review you would be. I think I could take up the next 50 minutes to discuss differences between them both. But what I could do afterwards is perhaps send you some papers on rapid reviews and scoping reviews.
Thank you, David. We will hold off for all other questions until we hear from Adrienne and Chantal. So Adrienne and Chantal, off to you.
Okay, thanks, Adele. That's great. So what I'm going to do is I'm just going to give you a bit of a flavor of some of the initiatives that we've been involved in, and actually sort of starting from where David left off, indicating that there was limited published literature to guide the process for how we should do things. Then we had to figure out what's our starting point. And then, so from that, we started as systematic reviewers, sort of with widely accepted systematic review standards, so those would be Cochrane and non-Cochrane, but then had to determine in the process of where can we make concessions to accommodate, an expedited turnaround time or something that's a product that looks a little bit different than what a systematic review is. And so as a result, sort of in the process of doing the knowledge to action work with the Champlain-Lynn, developed what is an 8-step rapid review process. In the process of testing that through, to try to come up with something that at the end of the day is much more like an abbreviated and accelerated version of a systematic review. And so to give you a sense of the initiatives that we've been involved with, so going from left to right, starting with the knowledge to action work that David had described with our local health integrated network. From that, we had done some work with our local folks, our decision makers at the Ottawa Hospital, a little bit of work with Cochrane, and then some externally commissioned service contracts. So, just to recap a bit, so the knowledge to action work, during that 2-year window, we had done about 18 rapid evidence summaries, and a slide later on, we give you the website, so you're welcome to go and check them out. But just to give you a sense, looked at clinical interventions, rapid reviews for that, looked at diagnostic and screening questions, and then that broader sort of health systems, health service initiatives. And we had requests that came from a variety of stakeholders in that LIN, and as David described, was quite a rich process. And so from that KTA work, there was interest locally at the Ottawa Hospital to do something that would meet their needs in getting evidence in a certain time frame. And so in the 2012-2013 time frame, looked at developing a pilot program to provide a knowledge support service focusing on rapid reviews. And during that time period had done 2 projects looking at therapy effectiveness questions, and then more recently had done a 1-pager rapid assessment looking at gamma pod technology for breast cancer. So that was to then inform a purchasing decision for the hospital. And so from this, we sort of garnered that, there are strong signals that this would be, there's more interest to do this sort of longer term. In terms of other things we've done, so from the KTA work, then folks here published our approach in 2012, and that's something you can find in the Journal of Systematic Reviews. And so what was interesting is sort of something that we felt was, of local relevance and of need here once publishing it. Didn't realize how interested other people were in it. So you can see sort of from our accesses, which was kind of neat from us. And so, from that we've done, I guess, about 25 or so rapid reviews, have done some training and education, as you sort of see on the screen here. We disseminate them as much as possible, and so we have, this is the website that I was referring you to, so you can go on and check out some of those rapid reviews and publish where possible. And so the rapid review that folks had done here on looking at short stay units as part of emergency departments is something that's been published. And so then of course we're interested in looking at rapid review methods in general, and have started networking with various groups to do this. And so I thought we'd throw up a slide and let you know that we are in contact with other organizations who are doing rapid reviews. We're at the initial stages of looking at a rapid review network with other organizations to do this. If that's something that you do within your organization, we'd love to hear from you, so feel free to send us a note. We have our emails are provided at the end. So I will just pause there. Chantal's going to go on and talk more about the Cochrane Response initiative, but I will pause it there for now just to see if there are any questions. And of course, as you think of questions during the session, feel free to just send them in the chat room, and if we have a few minutes at the end, we can address them.
Adrienne, Stephanie would like to know how many people were involved to produce 18 rapid reviews in 2 years?
Hi, this is Chantal here. I would say that we had approximately 1.5 staff working on it, so a research associate as well as another research assistant helping to screen citations. We also involved an information specialist, especially in the latter stages of, I should say, the initial project that we worked on, we did not how formal search is done by information specialists, but very early on, I'd say probably around project 4 or 5, we started to involve a well-trained information specialist. And then we also have an information specialist assistant who would help actually manage the references as well as all of the article ordering. So that really facilitated things. So all in all, working full-time over the 4 to 6 weeks, we had, in terms of research personnel, we would have, I'd say, 1.5 full-time equivalents in terms of dedicated staffing.
Perfect. Now, there's another question. Did you use software to support screening, extraction, risk of bias, etc.? If so, what was it?
Yes, initially we did not, and then very shortly into, again, probably the 4th or 5th project, we went to using Distiller as systematic review software.
Thank you. Now, Elaine asks, how much detail is necessary for risk of bias assessment in a rapid review? If reviewing mainly RCTs, would the Cochrane collaboration risk of bias tool be sufficient by itself to give a brief sense of quality, or would you need something extra than to interpret the findings in relation to outcomes, like the grade approach in addition to the risk of bias tool?
So when we were looking at doing risk of bias assessment for RCTs, yes, we had used the Cochrane risk of bias tool, and we were also thoughtful that if there were other biases, given that there is one domain that looks at the biases, if there were things that were relevant given to the question and the type of studies we were looking at. So for example, if we were looking at cluster RCTs, we would look at recruitment bias. We were also thoughtful of that. So yes, we had used the Cochrane tool for RCTs.
Thank you. And one more question. What do you think is the future role of automation in our methodology, either automated searches or visualization for data analysis?
So why don't we come back to that question at the end, because there are some items that we're going to be dealing with sort of through the talk, and we can come back to the question at the end, Adele, if that works for you.
Sounds great. Please continue.
Okay, so why don't I just carry on then? And so before Chantal goes into the Cochrane Response Initiative, what we thought we would do is then give you a sense of what our approach is. So we've walked you through some of the initiatives we've been involved with to actually do these. So let's talk a little bit about how we do them. And so as David had mentioned, there wasn't, a universal definition of what was a rapid review, and so what we've used to define this process is to talk about it in terms of being an accelerated or abbreviated systematic review. And of course, still in the process of this, even though we're making concessions with respect to methodology, still aiming for it to be standardized, transparent, and then obviously efficient to meet the needs of the end user. And so this slide gives you a sense of the stages that we use to undertake a rapid review. And so some of these will be familiar with you, for you, because you are familiar with systematic reviews, or most of you would be. So I think it's the upfront part that is a little bit different, that allows us to then ensure that we have the right scope, but that we're also able to meet the needs of our end users. And so our first step into this would be a needs assessment phase, where we would have a phone call with the potential end user, and we would get a sense of, broadly what their question was, what they were using this for, just to give us a sense and thinking through, is this a topic that we could do a rapid review on? And so that next stage, a topic refinement, is really where we've had a chance to scope out some of the literature, think about some of the PIHOs, and walk people through those elements to ensure that we're understanding what it is that they want. And it gives them also a sense in terms of what type of rapid review product we might provide to them. And Chantal later is going to walk you through sort of how we've depicted our products to be, and sort of the resources that might be needed for that. And that stage 2, that topic of refinement, really becomes the basis of setting up a contract. And so that's that third phase where we set up expectations, determine budget, timelines, deliverables. We would have sort of interim and then our final end product deliverable as well with the end users, just to make sure that everyone is obviously on the same page and that in particular they're aware of what they're going to get at the end of the day. Stage 3 is and the time clock starts really once that contract phase is in place. Stage 3 is protocol development. So coming back from stage 2, walking into that to that third stage is, we have a sense of their PICOs, but then we're really fleshing out the details with the end user and putting some more feet to the actual methods that we would use for that. Stage 4 is the lit search. As you would take, and we'll talk a little bit about some of the concessions that we make through those stages. So obviously you go through lit search, your screening and study selection phase, your data extraction, your synthesis, and then we come to report production. And our time on the webinar doesn't allow us to really go through some of what has been developed iteratively during the process of producing an end product, but we've really tested and worked with various formats and thinking about what's actually relevant to the end user. And then that last stage is we've allowed them time to look at the final report, and then if they, if we have any feedback or dialogue based on that for any adjustments, and in particular thinking about implications and thinking about what this means in their context, that's where we have an opportunity to really get some helpful feedback from them. So you may be curious as to some of the ways that we abbreviate methods, and so this would be in the context of a rapid review that might take anywhere from 4 to 16 weeks. And so that, as I mentioned before, the topic refinement stage, that's that that's that time where you're fleshing out, you're doing a scoping search to then figure out what's going to be feasible in the timelines, and are there ways that we can tailor the scope to, or the review methods to meet their needs in the time that they need it. In terms of searching, we would limit things to 2 to 3 key databases. We would limit based on language, so focus on English, mainly English. There have been some projects we would focus on English and French. We would definitely focus to any articles that would be available locally to us through our library services, and they're available electronically. And as well, we will look at year restrictions if it makes sense to do that for the topic. In terms of grey literature, we would do grey lit searches only if it's feasible given the timelines. And if we do, we would limit it to just a few websites or relevant organizations. In terms of screening, we very much take a staged approach when we do these. So we would look first at high quality systematic reviews, and that would really be our focus. And should there not be systematic reviews available, or not very many, or they may not include very much in terms of literature, then we may then look at other study designs like randomized control trials, non-randomized trials, and observational literature. And then as well, if it makes sense to, depending on the topic, we would focus to geographic regions of interest. In terms of extraction, we would only extract the most relevant information, so it would not be a comprehensive extraction. And that, again, would also depend on the type of rapid review product that we would be doing for the end user. In terms of synthesis, it may be just a narrative synthesis. There may be an opportunity for meta-analysis, or we may do something that's more like a vote counting, where you do still get a sense of perhaps consistency and direction of effect within the literature, or it might just be an evidence mapping where you're solely just categorizing included studies based on a number of variables. The report, we try to do it as an executive summary style, so we do limit it for you thinking of the client, the end user for this. So I have here 6 to 8 pages is generally where the main report sort of lies. In terms of process and methods, so it's definitely something where along the way, depending what unfolds with the literature and how we need to handle things. There may be post hoc adjustments, and so that's something that we work with the end user along the way to make sure it still meets their needs in the time frame. And what's key to our process is that when we're doing these, we have someone on call. If we need to have a quick phone call or send an email to, that they can turn around a response to us in a timely manner. So, now that we've explained a little bit of our process, we would like to hear from you. So what do you think? In thinking through this process, is this something where you would feel that dual extraction of data is needed? You can cast your vote now onto the interface, and as some of the results come through, Adele will post the aggregate results to the whiteboard to let us know, yes, for sure, we do feel that dual extraction is needed, or no, single extraction is a reasonable shortcut to take in a rapid review. So I see some responses coming through. Thank you very much for casting your vote. And in just 1 minute, Adele will be able to publish those results to the whiteboard. I'm seeing some interesting results come through. So, and I'm just going to see, I think this is probably the most up-to-date here. So we have, of folks who responded, we have about, we're getting close to a 50-50 in terms of whether folks feel that dual extraction is needed for the process. So thank you very much. So there was a question earlier about grade, and so I am curious about, do you think we should include grade in our rapid review process? So again, please cast your vote to the whiteboard, and we've got some results coming through. That's great. Thank you very much. And so I will just wait a minute as those come through, and then Adele can publish those to the whiteboard.
Adrienne, we have a quick question. If you can just clarify what grade is and what dual extraction versus single extraction is.
Yeah, sure. So GRADE is a methodology that was developed a number of years ago. There's a GRADE working group, and a lot of those folks are connected with Cochrane. And so that is the framework that you would use for interpretation. So it addresses a number of domains of items you need to think through when interpreting your evidence. So one deals with a risk of bias, another deals with inconsistency of the evidence among studies. One deals with imprecision, so that's talking about the wideness or narrowness of your confidence intervals and whether it straddles. If you have something that seems to be statistically not significant, does it straddle both appreciable benefit as well as harm? So that's something you need to factor through. Publication bias is something as well that you need to consider, as well as directness, if I've covered all 5 off. And so for dual extraction, where we were talking at that stage about your data extraction. So in the phase of harnessing information from your studies, do you have 2 people do this to ensure everything is comprehensively captured? So the results have been published to the whiteboard. So thanks to folks who have voted, and I see we have quite a few who feel that yes, indeed, we should be considering grade in the rapid review process. So maybe what I'll do is I have here the opportunity to pause for questions, but maybe what I will do is keep your questions coming through the chat room. I just want to make sure that Chantal has enough opportunity to go through the slides as she wishes to, and then we can postpone those questions for a later time in the session. Thank you.
Okay, so I'm going to jump in here now. So now that you have been provided, let me just change slides here. So now that you've been provided with a description of our rapid review approach, we wanted to give you an overview of the spectrum of the rapid review products that we've produced to date. So you'll see on this diagram in front that our products have been categorized into 7 different types up to this point, with evidence briefs at one end of the spectrum, and these are usually done over a 24-hour to a 3-week period of time. They're very short and concise reports. Then at the other end of the spectrum, you have what we've done, where we've done a traditional systematic review, but within a shortened time frame, and we've not cut any corners in the process, except provided the findings in an executive summary style report. So in between, really types number 2 to 6, we've done a variety of rapid review products, from a rapid evidence map or a scoping exercise where we've only included what we're calling off-the-shelf evidence in the form of systematic reviews, health technology assessments, or clinical practice guidelines, plus or minus the inclusion of primary studies, to us doing what we call rapid reviews, where we again have included both off-the-shelf sources of evidence and our primary studies, which in some cases have been clinical trials and in other cases have been types of observational studies. So for us, what really distinguishes between these products are differences along key dimensions, which include length of time to actually conduct the rapid review, whether or not we've used any shortcuts during the process, and again, as we've alluded to, the level of analysis that we're able to provide. So whether we're simply just able to categorize or classify the information, or whether or not we're able to do something more formal in terms of meta-analysis. And so all of this is really dependent on the question being posed, the scope of the question, and again, how much evidence we come across and how much literature we have to go through. So of course, another important dimension for us is providing a risk of bias assessment or quality assessments of the included studies. And we try to do this wherever possible. So in general, I hope this gives you a general picture of how these products can vary. And I think what we want to emphasize is in that by no means is what we do in the form of rapid reviews cookie cutter. It seems that each product sort of takes on a life of its own, and each one has different nuances, but we consider these key dimensions across all of the work that we undertake. Okay, so what I'd like to do now is tell you a little bit about our involvement with Cochrane Response. So Cochrane Innovations is a newly established program by the Cochrane Collaboration, for those of you that aren't familiar with it. And the goal of Cochrane Innovations is to provide a mechanism by which the collaboration can respond to requests from external partners who wish to commission reviews. So our approach was used as the basis for developing this new rapid review from Cochrane called Cochrane Response. So currently there's a small pool of groups that have been assembled to undertake these requests, and we're calling these Cochrane Response units. Now, members of these units are experienced Cochrane authors as well as active members of the collaboration. So, Cochrane Response. Each response, the way that the guidance has been written, requires that you have at least 2 systematic reviewers involved. As well, you need 1 information retrieval specialist who's experienced. As well, content expertise is very important. And of course, having access to the collaboration, that's very much facilitated. As well, important for Cochrane Response is the necessary input of the client or the commissioning partner. Now, Cochrane Response adds in the process of peer review periods because we do have access to input from across the many content and method experts that make up the collaboration. So for example, depending on the topic, we can go to a particular Cochrane review group. We may want to access some expertise from a particular field or a methods group. Each response is to be placed on an 8 to 10 week schedule and has intermediate deliverables that we schedule throughout this period just to make sure that we're on track. The intent is to eventually publish all these rapid reviews through the Cochrane Library, making them available for other decision makers. But at the moment, they're only currently published on the Cochrane Innovations website. So it was actually this time last year that we were undertaking our first Cochrane Response. This ended up being a 10-week project for the Children's Hospital Association in the U.S. to inform the U.S. Task Force for Children's Surgical Care. So we worked with a tremendous talented group of pediatric surgeons who became our assembled panel, and they were very engaged throughout the process and very responsive to any questions that we had, given we had such a short turnaround time to work with. Specifically for this project, we looked at whether complex children's surgeries in specialty centers reduced death, time in hospital, and complications following surgery. Our literature search initially yielded over 8,300 records, and we were trying to ascertain the studies that pertain to the children at high risk who had had surgeries of the brain, chest, stomach, and pelvic region, and had undergone these surgeries in specialized centers. So having gone through all of this, at the end of the day, we came up with 62 observational studies, and the evidence suggested that specialization versus non-specialization may be generally effective for reducing mortality after pediatric cardiac surgery, but the evidence was really limited thereafter to draw any other conclusions. Nonetheless, it was an important piece that the U.S. task force had commissioned. Now, you can access this full report. It's on the Innovations website, as I've mentioned, at the link provided below. And if you have any other follow-up questions with regard to Cochrane Response, I'd encourage you to contact Dr. Lauren Becker. He will definitely answer any questions you might have. And again, we've provided the Innovations website there for you below to access. So I know we have a pause here for questions, but I'm thinking what I might do is I just have a few slides left, and then we can take general questions at the end if that's all right with everybody. So throughout all this work that we've done, we have faced certain challenges. As both David and Adrienne have mentioned, to date there's no agreed upon definition of what constitutes a rapid review, and we think this is really necessary in order to move the science forward and further developing the methodology in this realm. As well, it's been difficult to find rapid reviews in the published literature, and again, we've had some discussion about that already today. And we think that might be part of what we're calling the iceberg phenomenon. So we think we've identified the tip of the iceberg. We've identified groups, and more groups seem to be popping out of the woodwork that are doing rapid reviews. But I think several of these rapid reviews are sitting on websites or shelves, and we're just not aware of them. And I think it begs the question as to why these studies aren't being published, and an interesting question to address. As well, empirically, we don't know about biases in taking some of the shortcuts that we take. And related to that, do rapid reviews provide similar results to full systematic reviews? We're not sure. We hope to have some answers on that front soon. As well, do decision makers think it's even problematic? Do they have an issue with us potentially introducing bias in taking certain shortcuts? Another challenge for us is how best to deliver this information to our end users. You know, we're looking for a very succinct, readable, and usable format. And I think our motto is that we feel layout has been equally as important as content and knowledge that we produce. And we've been thinking this through, and we've had some discussions that perhaps the traditional IMRAD approach of presenting your information in terms of your intro, your methods, your results, and your discussion, maybe the structure isn't suitable for all decision makers, and we have to think outside the box. So of course, with challenges also come opportunities, and I think one of the big opportunities for us is knowing that we're able to deliver evidence in a timely manner, especially when evidence would not have otherwise been used. Another opportunity for us is that we continue to foster discussions and linkages with key stakeholders. Engaging in this work as academics has afforded us the ability to directly engage with decision makers, which has been a very interesting process for us. And as well, testing how best to deliver this information. I think we're going to need a bit of creativity just to ensure the relevance for the delivery format. But I think there are opportunities in terms of how we could better package the rapid review information. So lessons learned along the way, I think for our group has been, and we emphasize this I think in all of the training and talks that we give, is that there's always a balancing act between breadth of the evidence and the depth of the rapid review synthesis for particular questions. That's just the nature of the beast. Sometimes, as David indicated, we're able to go deeper, and in other times we're just able to take a cursory look, again depending on the question and the volume of information and the timeline. We feel client and user engagement is vital to the rapid review process. As we had mentioned, the need to identify a go-to person who represents the client, the commissioner, the panel, what have you, that's requested the review. It's important to have them on board. So we asked to have somebody on call who can answer questions and be our conduit for information so the process is installed for us. As well, institutional buy-in, it's required as well if you're trying to successfully develop a rapid review program. So as Adrienne mentioned, we've been doing work for the Ottawa Hospital Technology Assessment Program, the program we started. And for us, we've come to realize that there's a need for awareness of not only our products, but the program itself within our own hospital. And really this buy-in has to start at the top. Another lesson learned of many is that you need experienced and skilled systematic reviewers. Doing a rapid review, we've come to realize, can be very intense, it can be overwhelming, and there has to be some comfort level with the abbreviated process that the reviewers are taking. And to try to mitigate some of that discomfort, we've tried cycling through our senior research associates through this rapid review experience so everybody gets a sense of what it is to do a rapid review. Just to close here, some practical considerations, and again, we've talked about some of this, but for us, we're still thinking through the incorporation of peer review into the rapid review process. This requires additional time, and the question is, how feasible is it? And if it is important, how can we work this in to optimize the time and the resources? We've also mentioned grade, and we are grappling with the incorporation of grade, as this too requires substantial time and effort. As well, when rapid reviews are done, what impact are they having? And if we are thinking through evaluation, which we think is a very important piece, this has to be well thought through at the beginning of the process. And for us, we'd like to take some time to do that because evaluating the impact is important. To date, we haven't done anything formally. We've only been able to do some informal impact assessment work through key informant interviews. It gives us some sense of how we're doing, but I think more formal evaluation is worthwhile. And lastly, ensuring the quality of the work that we do and the completeness of the reporting is really important to us. So initially, we didn't always include a methods section in the rapid evidence summaries that we did for the Knowledge to Action program. But again, very shortly into the process, we went back to including a method center. We just weren't comfortable not having that level of transparency in our reports. But again, we're grappling with the best ways of doing that and ensuring quality. So to close, and I'm sure if others have heard us give this presentation or parts thereof before, for us, rapid reviews, it's still an evolving process. There's no doubt about that for us. But we advocate that if trying to get at truth, we think that narrative reviews fall short of the mark. Traditional reviews, if they're done well and of high quality, get the closest to truth. But we'd argue that rapid reviews fall somewhere along this continuum. And again, we suggest that at least having some evidence in the form of a rapid review may be better for informing healthcare decisions than no evidence at all. So I will leave it there, and we can jump into some questions.
Thank you, Chantal. All right, so we'll start with a few questions. Nani would like to know, do you evaluate the quality of included documents in the rapid review? Why or why not?
Are you asking, do we evaluate the included studies? If so, we do. We provide, we do quality assessments and risk of bias assessments. Where we have established tools, we will use them.
Perfect. Now, Irene would like to know, do you think if your stakeholders, do you think if your stakeholders were aware of the many evidence databases currently available, example evidence.org or guidance websites, they wouldn't need to rely on experts as much to conduct rapid reviews? What is this level of awareness?
Could you please repeat the question? I wasn't able to hear it properly.
Do you think if your stakeholders were aware of the many evidence databases currently available, such as evidence.org or guidance websites, they wouldn't need to rely on experts as much to conduct rapid reviews? And what is the level of awareness?
I think we should always make sure that we have content experts as part of the process, because there's a lot of issues of nuancing, and I would always want to include content experts. I think it would be a very slippery slope not to include them.
Thank you, David. Now for next question. Let's see here, we've got quite a few waiting. If you, to save time, have a search strategy to limit searches to SRs, Cochrane, and others, can you rely on the grade levels in the systematic reviews? Most systematic reviews done in the past 4 to 5 years use grade. As a reviewer, it's more difficult to apply grades since you don't have access to primary RCTs.
Absolutely. So, I mean, if a review hasn't done great, it's very difficult for us to go through, and the time doesn't permit us to do that either. So if a review has done great, then I think we would rely on what it is that they've graded, especially if they've made it transparent.
Perfect. And another question we have from Melanie, do you evaluate the quality of encoded documents in the rapid review? Why or why not?
So when we, so when we go to include systematic reviews, for example, we will use the AmStar tool to assess for the quality of conduct. And when it comes to something like a randomized control trial, yes, we would use the Cochrane risk of bias tool to assess for its risk of bias and report that information in the report.
Perfect. And another question we have from Elaine, with Cochrane Response Rapid Reviews, complex pediatric surgery, what way did you use the risk of bias to interpret the findings? It looked like you just used the percentages and positive and negative findings to determine interpretation.
I think, to answer your question briefly, because the studies were roughly all of the same level of quality in terms of them all being observational studies, as well, we had assessed them using the Newcastle Ottawa scale, and again, they all came out roughly of the same level of quality.
And the other thing too, I think with that is you'll notice the way that we had framed our conclusions is that we were cautious, and it was because it was observational literature, and given the limitations with us, the way we were able to approach the synthesis in the time frame that we had to do that one, and also given what came of the quality assessment of those studies. Thank you for your question.
Great, thank you. And we'll finish off with one more question from Alexis. Are you aware of work that has been done to quantify or characterize the potential biases of taking an abbreviated approach compared to a conventional systematic review? For example, precision, direction, or magnitude of bias, or any work that assesses the impact of such flaws methodologically on policy decision making?
At one level, I think we're very aware of some of these issues. So, for example, we've looked at the bias by excluding abstracts from systematic reviews. There's been many studies looking at this important issue. And while I agree with you that bias is extremely important, I think we also need to think about the decision maker, the requester. Often these people are quite aware of the issues at play, but they have an emergent decision that they need to make, and they'd rather have some evidence than no evidence at all. And I think there's a very important issue there. That we can't always deliver a perfect, pristine answer. But an answer for a decision maker who needs to make an emergent or urgent decision, I think is very important. At least, certainly, for example, the CEO of our hospital is perfectly aware that what we might deliver is not perfect, but it helps them enormously in decision making.
Great. Thank you very much, David. Now, I'd like to thank David, Adrienne, and Chantal for their discussion today. Let's all send our speakers a round of applause by clicking on the applause emoticon. ask you all to please click on the link that I have provided through the chat room to provide evaluations for today's webinar. I would like to thank everyone very, very much for joining us today. We really appreciate your time and participation. And once again, I'd like to extend a great thank you to David, Adrienne, and Chantal for speaking with us today.